Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 440 of our pharmacotherapy series, which majors in prostate cancer. The next case reads, TCW is a 67-year-old man who began routine screening for prostate cancer with his primary care physician 15 years ago. His prostate-specific antigen, abbreviated as PSA history, is listed below. His prostate-specific antigen drawn on August 5, 2012 is 6.68 nanograms per milliliter. Digital rectal exam, abbreviated as DRE, is negative. He has an excellent performance status, being fully active and able to carry out all pre-disease activities without restriction. On physical exam he is well appearing with no apparent signs of distress. He has no known family history of prostate cancer. When asked about his social history, he said that he drinks socially with an average of 1 to 2 drinks every month and has never smoked or used illicit drugs. His past medical history is significant for hypercholesterolemia, hypertension, and depression. His current medications include the following: atorvastatin, lisinopril, and sertraline. He has no known allergies. Pause the video and carefully scrutinize the table summarizing his prostate-specific antigen history over time. My next question to you reads, from the assessment above, what would have prompted TCW's primary care physician to refer the patient to a urologist? Using prognostic factors to stratify the risk of the cancer recurring is essential to better characterize the cancer and to determine the optimal treatment. This is particularly important with a heterogeneous disease like prostate cancer. Patients with a high risk of recurrence will need more aggressive treatment, whereas those with low risk can benefit from a more conservative approach. Stage of the tumor, prostate-specific antigen, and Gleason score are prognostic factors that can be used by the provider to calculate the probability of a patient recurring in the next 5 to 10 years. Utilizing these factors and incorporating the patient's life expectancy will help the physician to determine the best therapies for their patient while maximizing quality of life. We will now briefly address life expectancy. There are a number of men who will die with, not of, their prostate cancer. Autopsy data has shown that as many as 7 out of every 10 men who died of various causes had prostate cancer at time of death that was undiagnosed. Estimation of a patient's life expectancy can help determine the extent of benefit of potential life gained from treatment. Men with short life expectancies are at low risk of developing any symptoms of disease, or morbidity, before their demise from another unrelated event, and therefore will likely not benefit from definitive treatment. Conversely, Younger men otherwise in good health are likely to need treatment as they have a longer lifetime in which to develop a recurrence of cancer that can be a cause of morbidity and mortality. Although insurance life expectancy charts, such as the Minnesota Metropolitan or the Social Security Administration life insurance tables, can be used to determine potential life expectancy, it often is a comprehensive clinical determination by the patient's healthcare team, weighing a number of factors, including their overall health, quality of life, comorbid conditions, and family history when determining a treatment plan. Let's now briefly look at prostate-specific antigen. As previously discussed, serum prostate-specific antigen level is used in screening for prostate cancer detection. It is also a prognostic factor used as an aid to determine treatment because a higher prostate-specific antigen level is associated with an increased risk of more advanced and potential progression of disease. The more prostate cancer cells there are, the more prostate-specific antigen is being made. Being able to determine how fast the level is rising is another way to assess the cancer's ability to potentially recur and progress. However, it is also known that not all prostate cancers will produce elevated prostate-specific antigen levels. It is another tool that may help the practitioner to assess the risk of recurrence in a specific patient. As mentioned previously, men with prostate-specific antigen levels of 4 to 10 nanograms per milliliter have a 30% to 35% chance of having prostate cancer. That risk doubles if the level increases above 10 nanograms per milliliter. A number of other screening modalities have been developed in order to better define a patient's risk for prostate cancer. Observing the time over which the prostate-specific antigen level rises, or prostate-specific antigen velocity, is a way of potentially identifying those men with prostate cancer versus those with an elevated prostate-specific antigen because of other causes. Determining the prostate-specific antigen velocity may help further ascertain those men who should have a biopsy performed. Upon diagnosis, a rapid prostate-specific antigen velocity can also suggest more rapid progression and can serve as a guide for treatment decisions. However, it is important to know the normal prostate-specific antigen ranges by age and that fluctuations in levels can exist because of the laboratory controls. Because of the fact that patient TCW had a prostate-specific antigen level of 3.21 in 2011 and 6.68 in 2012, there is concern that he may have developed prostate cancer. The Prostate Cancer Prevention Trial, abbreviated as PCPT, found that 15% of men with prostate-specific antigen equal to or less than 4 nanograms per milliliter and a normal digital rectal exam were diagnosed with prostate cancer. This percentage doubles with prostate-specific antigen levels between 4 to 10 nanograms per milliliter. Patient TCW's change in prostate-specific antigen from 2010 to 2011 and 2011 to 2012 indicated an increased prostate-specific antigen velocity, which can also suggest that further evaluation is necessary. The Baltimore Longitudinal Study of Aging, abbreviated as PLSA, trial of 980 men demonstrated an increased relative risk of prostate cancer death in men with a prostate-specific antigen velocity greater than 0.35 nanogram per milliliter per year, compared to those with a prostate-specific antigen velocity equal to or less than 0.35 nanograms per milliliter per year, with a p-value equal to 0.02. TCW is referred to the urologist for further evaluation. My next question to you reads: what additional diagnostic procedures can be done to definitively diagnose prostate cancer? What assessments can be done from the procedure for better prognostication of the disease? The American Joint Committee on Cancer, abbreviated as AJCC, developed a staging system for newly diagnosed prostate cancer. This AJCC-TNM staging system classifies the extent of the tumor according to the size of the tumor, signified as T, the extent of lymph node involvement, signified as N, and the absence or presence of distant metastases, signified as M. In general, if the cancer remains within the prostatic capsule, it is considered localized disease. If it has spread outside of the capsule or has invaded the adjacent structures, it is locally advanced and the cancer is considered metastatic if it has spread to other parts of the body. Next we will briefly consider the Gleason score. A Gleason score is the histologic grading of the tumor biopsy. It is calculated by adding the most common to the second most common growth patterns found in the core biopsies. This score is one of the most important factors when determining treatment and prognosis as it corresponds to how aggressive the tumor is behaving. An aggressive tumor is one that will grow faster and have a higher risk of metastasizing, increasing the likelihood of recurrence after localized treatment. There are 5 distinct patterns of growth from well, that is 1, to poorly, that is 5, differentiated with progressive loss of glandular formation. Well-differentiated cancer cells are those that are most similar to the normal prostate cells and tend to grow and spread at a slower rate than poorly differentiated tumor cells that are more aggressive. Up to 50% of prostate tumors demonstrate more than one histologic pattern. By assessing several of the biopsy samples to find the most common growth patterns, the aggressive behavior of the tumor can be more accurately estimated. The added value of the first and second most common patterns can theoretically range from 2 to 10, with the majority of tumors ranging from 5 to 10. Cancer with a Gleason score of 6 or less, which is relatively well differentiated and less aggressive, is considered low-grade. A Gleason score of 7 is considered intermediate-grade cancer, and a Gleason score greater than 7 is considered poorly differentiated, high-grade. For someone with a Gleason score of 2 to 4, there is a 4% to 7% chance of dying of their disease within 15 years. A man with a Gleason score of 8 to 10 has an 87% risk of dying within 15 years if untreated. Risk stratification tools that incorporate stage, prostate-specific antigen level, and Gleason score have been developed and validated as they identify those men who are associated with an increased risk of recurrence and worse outcomes after localized treatment. These systems group patients who are yet to receive treatment as very low, intermediate, high, or very high risk to be used as a basis for providers, along with life expectancy and overall health of the patient, in the selection of initial treatment. A transrectal ultrasound-guided needle biopsy can be done to definitively diagnose prostate cancer. The biopsy specimen can be used in conjunction with digital rectal exam results to determine the prognostic factors of clinical stage and the Gleason score. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 441.